Lynn will not be able to join us today. Her stepfather has had a heart cath and is having to have bypass surgery today. And so she won't be with us. But I'd like to call for if maybe Gabby could help me determining if we've got a quorum with the subcommittee chairs on. Lynn won't be with us.
I think it's probably best for them to for us to go down the list, because finding people on this
Okay.
is a little more difficult. So Kendra Holm, are you on? Go down. Kelly Roker.
Hey, this is Suzanne Edwards. I am reporting for Kelly today.
Thank you, Suzanne. Rima Stevens or Ashley Bullington?
I'm on the call. It's Ashley.
Thank you, Ashley. Kelly Vaughn or Colleen Horn?
I'm on the call. It's Colleen. Kelly's en route somewhere and she may have poor service.
Okay, thank you. And then Crystal Smith.
On the call, as is my co-chair, Carrie Page.
And I don't know if you heard that, Gabby. I think Carrie Page is going to be like co-chairing, kind of taking over. She and Crystal are going to be tag teaming, but you said both of you guys are here?
That's correct. Carrie will be giving the report.
Thank you.
This is Carrie.
And is Jessie Gibson, past chair, on the line?
Yes, I am on the line, and I don't know if you guys saw Kendra's note in the chat, but she is also on. She just could not unmute.
I think my husband wishes I would not be able to unmute sometimes. Okay, so it sounds like we have a quorum.
You do.
Can I get somebody to give us a recommendation to approve the minutes from May?
Hey, this is Ashley Bullington. I'll approve the minutes. I motion to approve.
Somebody second?
This is Suzanne. I'll second.
Any people who are opposed, speak up. Okay, I don't hear anybody who's opposed, so we have the minutes from May approved. Any new members on the call that we can welcome?
This is Jennifer Talkington. I am with Phoebe Putney.
Welcome, Jennifer. Are you PI or what do you do? Registry?
Yes, I am the trauma registrar, project management.
Excellent. Welcome.
Thank you.
This is Rebecca Butler from Coffee County. I'm the trauma program manager.
Welcome. Glad to have you. Anybody else new?
Yes. Hi, this is Emily Russell. I'm one of the clinical educators for the trauma program at Grady.
Welcome. Okay, if not hearing anybody else, we'll move on to Liz's report from the Trauma Commission.
Thank you, sister wife. I was with our work husband all morning this morning on the JTAX submission. So yes, thank you. Welcome everybody. It's been a minute since I've actually been able to report out to this group due to a number of conflicts. And I think it speaks for this group's, which is, we always say, the longest standing group, and you guys are so independent, and it's great. This is where all the brain power and the expertise come together. So, so great work. And I just have a few updates for you. FY24 amendments, which are not, they're no longer based on your PVP performance, because we calculate that and roll it forward with your contracts. But we do, through super speeder and reallocation money, we do give you amendments which generate additional dollars for your trauma centers. So those are in process, as well as your FY 2025 contracts. So just check with your facilities, make sure if you're having any barriers or anything, getting anything through, just let us know what we can do to help. I think so far most folks are, we're pretty good with the execution phase of those. So thank you for everybody's attention to that. Just a quick revenues update, because we get monthly updates on super speeder revenues. So for FY 2024, the revenues were up 1.2 million ahead of FY 23. So that's actually a nice little bump up, and that money will be reallocated as part of the 2025 legislative process. So when you see the governor's budget recommendation come out, you'll see that in there. Let's see what else. Oh, this year, level 1s and 2s, you won't notice much new in your contract, but 3s and 4s, very pleased to say that now everybody is on. We revamped the funding formulas completely, and that has been needed for a long time. Level 1s and 2s, Katie and I actually had to have one of our accounting consultants draw out a piece of pizza pies to kind of figure out what the distribution formulas really meant. They've been in existence since 2007, since the inception of the commission, and they just didn't really make much sense any longer. And the reason it was so confusing was because it was a weighted average, with the level 1s getting the majority of the readiness, and then the level 2s being a portion, again, weighted portion of the readiness funds. And then level 3s and 4s were always at a stipend. Now that we have good data for levels 1 through 4 readiness costs, we're actually basing your readiness funding on the readiness cost results. And that's specific for the levels 1, 2, and 3. Level 4, the average readiness cost that we got from the survey that we did was only $80,000. We think that's pretty much a gross underestimation. We'll redo that survey at some point, not too soon. I know, I know those surveys are, a little bit cumbersome. We'll probably do we're going to target doing a level 1 and 2 resurvey again before we do 3s and 4s, because we want to see what happened to the costs once the ACS verification deadline passed. I'm sure you're having to spend more money on your programs to keep yourself ACS compliant. So we certainly want to keep up with that. But for the level 1, 2, and 3, now everybody is at the same cents on the dollar. You always hear Dr. Ashley talk about, his battle cry is 7 cents on the dollar. We're only funded our readiness costs at 7 cents on the dollar. And with the funding that we have this year, you're actually 1s, 2s, and 3s are at 9 cents on the dollar. Thank you, Katie, for sending that over to me. So we created multiple different scenarios of how this could shake out, and it just seemed to make the most sense when we looked at the distribution to keep 1s, 2s, and 3s on the same percent of what the readiness costs are. And then for level 4s, in our $61 million proposal to the House and Senate, we had proposed to fund level 4s at 100% of readiness, because those costs were so low at $80,000. But we only got an additional $4 million, and we just didn't have enough money to do that 100%. But we were still able to fund level 4s at $40,000 readiness, which is a very significant increase from last year. So you should all be very pleased when you look at your contracts. In addition, for level 3s and 4s, we know you're the most vulnerable with costs, et cetera, because the readiness funding is much less. we're continuing to fund the registry costs at what the actual cost is. So we collect those from the vendor, and we're hoping that something will break loose with this registry environment at some point, because gosh, it's getting a little bit ugly, and I know we're all feeling the pain of this. We're no different. Gina has to, deal with that from a central site perspective. So we're just kind of holding tight and waiting to see what loosens up with that. Your performance-based pay criteria, this is the time of the year where that undergoes revision, and we will put out open comment period to look at that. One thing I think you'll all be pleased that Gabby is using her excellent formatting skills to create a tiered system for your meeting attendance, so that it's not all or none. I know we've gotten a lot of feedback where that's been a little bit tough. So, this is certainly not made to make you fail, but by the same token, we want the amount associated with meeting attendance to be worth you actually attending the meeting, and not something that you look at and go, well, I'll just forgo that amount of money and not attend the meeting. So we're continuing to work on that. So look for updates on that. As part of the FY24 reallocation money, I'm sure that Callie or Colleen will probably address this in the registry update, but there was approval for funding for an AIS 15 update course. Those courses are virtual. So the nice thing is you won't have to be in person, but I think at some point we'll probably do a full AIS 15 course, and we certainly could fund that. So, please keep that in mind if you want that in the future. But since we did the full AIS 08 course for those who needed to take the certification exam, the 15 update virtual course just made more sense at this moment. And one other thing I'll say related to the registry is that we're working to try to see what kind of IRR program we could stand up for level 4s, because we know you're a little bit challenged to have someone else in your facility IRR you. They may not have any familiarity with AIS. And we had a call about this last week, I think, in the afternoon, the same day that the level 3, level 4 call was. And it would have to be done on a reimbursement basis. I'm still getting some information from the company. There's one company in particular that has a clinical data validation module. So you can, it's exportable in Excel. You can actually go track your inter-rater score. It's got the different, everything you could imagine on every screen. Obviously for level 4s who don't admit, that's a little bit overkill, and it is quite expensive. So, but they are the only ones that offer it. Everybody else is more of a manual, we will re-abstract your records and put it on a spreadsheet and send it back to you. So I think something that's actually warehoused, as a module would probably be more helpful for folks. So more to come on that. Still just kind of learning more about what they're able to do pricing wise, since the level 4 low volume non-admitting centers, again, that would be a little bit overkill, but hopefully that will help us get a little bit more of a sight line into what some of the data quality issues before we invest a lot of time and effort into Arbormetrics with level 4, since you really don't have anything else for level 4s to support you in terms of benchmarking. And then I'll wrap up just with the finance webinar. Thank you so much. What a huge response to that. We're really excited about that. I did get a couple questions about, what's the PVP? Who's mandated to come? And I know that always causes great consternation about making sure that somebody who's required comes. We actually canceled the administrators committee meeting for that morning so that the administrators could attend that. We're not going to count that attendance for the administrators meeting towards that. It's just a freebie cancellation of that meeting. But I think it would be helpful because the administrators heard a whole lot of information on billing and coding and revenue opportunities at the May meeting with the finance session. And now the whole goal behind this session is for the folks that are in the various different departments of your billing, coding, managed care, revenue cycle, revenue integrity. I mean, I've seen so many job codes and departments. It's pretty amazing, but to get all those people together so they are speaking the same language. And the big reason for this and trying to make sure that everyone is really educated and getting the most you can out of revenue opportunities from a billing perspective is that there is language in the commission's code that says that the commission funds, the trauma trust fund is to be the payer of last resort. And to be honest, when we pitched the $61 million trauma system stabilization plan, we did get a lot of questions about trauma activation fees. A lot of the legislators are physicians and they're quite savvy about things like that. We don't want to know how much people are charging or how much you're getting and all of that. We just want to know, we have a suspicion that when you charge for trauma activations, you're not always successful in getting it. It becomes really complicated when the patient is admitted, and then the fee gets wrapped up into the DRG. But on the claim, it does indicate whether a trauma activation fee was paid or not. It's a yes/no thing, so it's not an amount of money. So we want to build a couple metrics that you'll be able to report. And yes, this will probably be on PVP, but this will really help us say, folks are in general not getting rich off of activation fees. That's not, it's not a big enough factor, or we may find a different, but we need to kind of know how to address it. So those are the two big reasons that we're kind of honing in on this. And I think it will help us build a little bit more out in terms of a financial dashboard and monitoring the financial health and well-being of our system. So I think I'll end it there, Tracy, unless there's any questions.
Thanks, Liz. Always a fountain of knowledge. Marie or April, are you with us today? Or Stacy?
Hi, everyone. This is Marie. Stacy is on the line, and I don't see that April is, so Stacy will be given the report for OMST. So let me just briefly say that the OTCPE reports have come in and we are reviewing those. I have two things that I want to bring up, but I'm not sure if Kelly Vaughn wants me or Colleen wants me to bring them up. They pertain to the registry. So can I get some feedback from Colleen on that?
I'm sorry, what were you going to bring up?
The change for the 2025 criteria and an update that we got from ESO this morning.
Sure.
Okay, I'll go ahead. So we have presented to the GCTE Trauma System Performance Committee and the GCTE Registrar Subcommittee a change to the Georgia 2025 criteria for the trauma registry records. And what we want to do is align our Georgia registry criteria with the NTDS criteria. The purpose of this change at this point is because our Georgia data quality processes and analysis through your participation with GINA and GQIP have matured our data system to a point that we need our criteria to line up with the national criteria. There won't be any more guessing year to year what the state criteria includes or doesn't include. And the 2025 year is a good mid-decade year to align for research purposes. And so we know there's a clean break in the data there. Your GQIP and TQIP data would be more comparable, apples to apples, instead of apples to oranges when you're looking at your reports. So we are open to comments and your feedback for a few weeks. And what we're planning to do is put the new criteria into the 2025 data dictionaries. So we welcome your comments, concerns, and once we reach the September 1st date, then that data dictionary criteria will be adopted. We had a quick call this morning with ESO, and It's our monthly state level call. Danielle wanted everybody to know that the ICD-10 code updates for V5 users will be released. She said in a few weeks, but I would anticipate it by the end of August. So if you haven't received your update, please reach out to ESO's tech support. And just so everybody knows, ACS has not released the 2025 NTDS data dictionary yet. So what this means is that the vendors cannot prepare the schema for the following year until everybody gets that data dictionary. So ESO is aware the delay will affect their development schedules for the 2025 updates, but they will work as diligently as they can. And that also affects our image trend friends because they will prepare the schema that is needed so that you can do your download from your ESO system to the image trend registry. So that's all I have. I'll turn it over to Stacy. She was having a little technical difficulties earlier.
Okay, can y'all hear me?
Yes.
Okay, thank you. Sorry about that. My computer completely shut down and it will not reboot. So I had to jump on with my phone, and apparently I've never activated the microphone for Zoom. So good afternoon, everybody. Just a quick update. Since GQuip, we have completed 4 level 4 consults through our office. And these consults are to help you prepare for designation, or if you have questions on being designated and just want to have a review of your facility. Me, Marie, and April can sometimes join us when she's not doing cardiac designations, but we did the 4 and we've gotten good feedback from the centers, and it feels like a good communication between us. So if your facility would like a consult, reach out to me and we can get one scheduled. Sometimes we just focus on questions that you might have concerning the Orange Book and your facility. And then some facilities like us to do a kind of a mock review day and go through all the stages. So we can do whatever fits your facility the best. We do have one consult coming up in a couple months. And then we have another designation coming up towards the end of the year. We are proud for Effingham. They are level 4 redesignation. And other than that, there's not many more updates from us in the trauma world. I know Kelly is still working with Liz to identify some either grants and working with some locations for air and ground across the state. And Richard and Heather are also working with some maybe training courses. But other than that, that's all I have for now.
Stacy, thank you for that report. And just as an update on the visits, everybody that has been surveyed in the past or can get ACS emails, they have emailed saying they're only now scheduling visits, I think September 25 and later. My facility is thinking about an mid to late April survey in 26, and we put in for our dates yesterday. That's how far ahead people are going. So if you do have one coming up in the next, say, 12 to 18 months and you haven't already requested a date, I would encourage you to go ahead and do that because they are working so far out with their survey and consult dates. Cheryl, are you on the line yet? She was running a little late. Gina, if you could go ahead and go, and we'll see when Cheryl comes back on the line. She had another meeting that was running long.
Sure, absolutely.
Thank you.
Glad to. All right. GQuip update. Thank all of you for getting your first quarter downloads in on time. I know it was a heavy lift with all the updates and changes, and so I really appreciate it. I'm happy to say I got the first quarter file to Arbormetrics yesterday evening. So hopefully it will be loaded soon. I'll let everyone know when the first quarter of 2024 is in the site from that standpoint. So I do appreciate everybody's diligence on that. And I know it will not be long before the September file is due. So hopefully that will go much smoother from that standpoint. We are working on building the next process measure that will be built in Arbormetrics, and that's going to be the VTE. We do have we have stood up the VTE work group. So that first draft of that has been sent to that group to kind of look at. That group's also looking at VTE protocol to hopefully kind of build a state generic one, like kind of like what we've done with VAP and multimodal that we can share with the centers. So that group has gotten started from that standpoint. We will have a call, our quarterly virtual, one of our 2 quarterly virtual calls on August 20th coming up. So, and then we will have what will be a fall meeting, since we didn't meet in winter. We kind of met in spring coming up on November 20th, and that will be in Cordele. It'll look a little bit different. You guys will notice that we're kind of shifting a little bit, so bear with us as we change what the GQuip meetings kind of look like. It may be that we have like one really big meeting a year and one kind of smaller meeting. So this meeting will look a little bit smaller, a little more intimate, and as we share data that way. So more to come on that, and we are working, and we have some tentative dates and location for the winter 2025 meeting that we hope to be able to share soon. And I think that's most of what I have.
Thanks, Gina. Anybody have any questions or comments? Cheryl, have you had a chance to join us yet? Well, we're zipping through this meeting. We'll start with our subcommittee reports. Kendra, are you able to speak now?
I'm here.
Yay!
Sorry about that. I had to log out of and log back in, so that seemed to fix it. So the Education Committee has really been working on 2 main projects this go around. And so the first one is the Trauma Program Manager toolkit or workbook of guidance for things that that trauma program managers at all levels across the state will need. So the first draft is complete. It's been sent to some of the stakeholders for initial review. I just got some feedback from Stacy at DPH last week. So thank you for that, Stacy. We're incorporating that, and we'll add that in for review by the rest of the work group and team. And then once that gets cleared, we'll send it back out to GCTE leadership and other stakeholders just for review, approval, input, guidance. And once that is complete, we hope to have it ready for dissemination and across the state, hopefully by October 1st. So that is our goal. The second project that we've been working on is some information and guidance and support for nurses in non-trauma centers across the state. We're calling it sort of the essential trauma nursing skills that we need nurses at these non-trauma centers to really be strong in or have a solid handle on for that early initial management and stabilization of the trauma patient until they can get them out the door and on their way to the trauma center. So Keith has been working on that for us down in Savannah, has got a poster ready and has been putting together a sort of a PowerPoint presentation with the information presented there. That the thought really kind of boiled down to it was better just to kind of have the information available in a way that was quick, bulleted, easy, so that it wasn't going to take a lot of time or training for staff across the state to be able to get this information. So we hope to have that ready for final review and dissemination by November 1st. And that is it.
Thanks, Kendra. You've gotten a lot of good work done this year. I've read about a third of the trauma program manager draft and really like what I see. So good job.
Oh, thank you. It's a fantastic team and yay for the folks who work on it. Thank you.
Sure. Kelly, or Sam, I guess, you're going to be reporting for Kelly?
Hi, yes, can you hear me?
Yes.
Okay, this is Suzanne. I'm the PI coordinator at Scottish, and I'm going to be giving the pediatric subcommittee updates for Kelly. Just a quick plug, we are currently in need of a physician team lead. We have our 2 trauma medical directors that recently started at Children's within like a month of each other. So they have been kind of bombarded with learning the system. One of the TMDs is from the Midwest, so he's learning kind of how things are done in the state of Georgia. So we are hopeful that one of them will be taking on this additional responsibility, but currently without an official physician lead for our group. A couple updates on what our committee's been working on. As you know, last year we rolled out the SIPA education. We have had some recent requests to our group for additional information and resources. So we're collaborating with those centers to provide that. And then we also have an outreach person who is helping incorporate all this, the SIPA education into the EMS trauma symposium talks. Our big project that we're working on is the creating a pediatric transfer toolkit. What we found is that it doesn't really exist. We have a model of one that looks like, based on the pictures, from like the 80s. So we've reviewed various documents from a couple of centers, and we're just taking bits and pieces of what we like to create our own. We've broken it up into sections that have been assigned to committee members, and our next steps are to review that and kind of try to piece it all together so we have like a first look and a first draft that will hopefully be coming out in the upcoming months. As far as pediatric readiness, Children's, we're hosting a Trauma Bay equipment tour next week with Piedmont Henry, so we're excited to have them come on up to Scottish Rite. Our new hospital, Arthur M. Blank, is opening September 29th, so once that's up and running and we get the kinks sorted out, we would be happy to extend to that campus as well. There's been a lot of talk around whole blood in pediatrics, and various centers are having meetings to discuss the use of whole blood and potentially incorporating that into MTP policies. So Children's is participating in a large multi-institutional study called MATIC-2, and this is it's gotten pushed back a couple times, but I think we're looking at a go-live date of November as of right now. Biggest concerns with that are looking at dosing, titers, and availability. So hopefully we'll have more to report at our next meeting. And then obviously, assuming if the recommendation is to move forward with utilizing whole blood, then we will be working on the education for that. And lastly, we have an internal quality project looking at EMS safe transport. It's basically data collection, determine how patients are restrained during EMS transport. Some of our pediatric emergency medicine physicians reached out to the trauma department, just noting that they are seeing a lot of patients come in inappropriately restrained. So we created a QR code that goes to like a quick 30-second red cap survey where staff can provide, how they were restrained, what provider brought the patient in, so we can kind of do focused education. That project was shared with the pediatric subcommittee, and I know that people were taking back to their own institutions to see if that's something that they want to implement, just so we can get a wider range. And that's really all I have to report. Are there any questions?
Thanks.
I do have a question. Can you hear me?
Yes. Is this Ashley?
This is Crystal. I was just asking, how much with that pediatric safe transport are you kind of working with the EMSC group at all with? I know that they worked with the DPH Injury Prevention Subcommittee to put together an education piece. And it's my understanding that it was, or at least it's headed to be loaded to the Georgia train system. So as you're identifying organizations with issues, can we turn them on to that particular resource that was developed? And then the other thing is, I know Josie mentioned the possibility of doing it at our facility, but I personally, before they would get into doing that, I would like them to watch that education piece too, so that they can better understand how these folks are maybe being taught. Does that make sense?
Yeah. Yeah, that does make sense. I know Kelly sits on the EMC, so I believe that it's been taken there, but we can definitely put something together to send out. And like the QR code that we have, it's pretty informal. It just mostly sits near the charge nurse, and people can just know to go and scan, and it's very, very brief, so it doesn't take long. So we've gotten a fairly good response.
Yeah, I only wonder, just simply because I know that the last child that I transported in a child restraints was pediatric restraints was 12-week old, and the facility that we were transporting out of was actually trying to get me to utilize the child's own device, which, as you know, an infant carrier would not be appropriate for that type of transport. So again, I think making sure our anybody that would be maybe doing that understands, how EMS is taught from at least initially, and certainly they are doing it wrong in some instances, but just being consistent.
Yes, no, that's a good takeaway. I'll take that back to Dwayne. He's helping us with all of the EMS outreach. Thank you.
Would you want other hospitals to be able to ask EMS to fill out stuff about safe transport, or is that something you're just doing at your facility?
Yeah, we shared it. It's actually the ER staff that are filling it out, not EMS. I mean, EMS is anyone's welcome to be in the code. But yeah, we did distribute a mock of that, so we would be happy to share that with the group if people are interested.
That would be great. Maybe if you can forward that to Gabby and she could send it out with the minutes afterwards, and that way we can just make sure everybody has access to it.
Yes, definitely.
And I'll see that we can get that training available so that they at least understand the kind of information that's being pushed out on the state level to our EMS providers.
Agreed. That sounds great.
Okay, thank you. Ashley, you're next with PI.
Hey, it's Rayma.
Oh, Rayma?
Yeah. Sorry.
Yeah, she's on now. I was just to let
I
y'all know
joined a
Rayma's
couple
on.
minutes late.
No problem.
So we continue to work on our standardization statewide of our time to definitive care. At our meeting in May, we talked a lot about trying to come up with a time frame for emergent and urgent transfers. We had a lot of input. A lot of people sent in how they are currently doing it. We didn't come to a definitive decision. I think this is something that we'll need some commission support on as well to determine what those are. What we also discussed was coming up with what are we looking at to decide if they're emergent or urgent, non-urgent. So that's what we left with the homework to do for our meeting that's coming up on August 13th, is things to look at to decide the urgent, emergent, the ones that we're really focusing on for that. And then after we come up with that, then we can set our timeframes.
And Rayma, weren't you asking for input from the TMD group too?
Yes, and I did receive that information. So that's part of what we'll be discussing on August 13th as well.
Right.
We discussed how the transfer centers and that work. So I actually went and visited our own transfer center. It is phenomenal. So I'll be sharing that with everybody as well. We do have a new initiative that we're going to discuss at our meeting in August as well, and kind of be working on something more than just the time to definitive care. And that's about it for right now.
Thank you for your report. And I really appreciate you picking up. You and Ashley have done a great job with the group. So thank you.
Absolutely.
Thank you.
Colleen, are you ready for the registry?
Sure. Kelly and the leadership group are working through the AIS virtual course process. We reviewed the GTC required education that all registrars are required to complete the new TQuip new for 2024 education module, and at least 50% of the TQuip monthly education experiences. The registry subcommittee PowerPoints are located on Basecamp, and TPM should have logins to access the PowerPoints for consultative and verification visits. And I know that Kelly and the leadership group are working through the AIS virtual course process. And I think that's about it. A lot of ours, Marie and Gina cover it in their talk. And I think that's about it.
And did I just miss it? Or the other thing was that I think the commission was going to help us pay for some 2015 AIS coding course.
Yes, I believe so. But Kelly and the leadership group are working through that process, and I don't have that information. So Gina or Marie or anyone who can add to that, please feel free.
Hey, it's Liz. Yes, we are. There is a line item for the AIS 15 update, as I mentioned in my report. So we will be getting that out. We'll just have to figure out a registration process for the funded positions. So
thank you, Liz, and don't slap me on the hands for missing that.
No, good.
Okay, Carrie and Crystal.
Hey, good afternoon. So I'm going to be giving the report for the injury prevention subcommittee. Special Events Task Force helped with the Georgia Trauma Systems National Stop the Bleed Day webinar that was on May 23rd. We helped provide instruction for the 3 virtual sessions and that included more than over 300 participants. Currently in the middle of the Stop the Bleed training blitz, which is for the back to school blitz. And so far, more than 400 attendees have participated, and we have over 900 participants to date. Anybody is welcome to help with those. We still do have a few slots for instructors if anyone is interested. And just to throw out some crazy numbers, as of this morning, we had 1,584 registrations, 3,037 event page views, 900, sorry. Um, 900 post-session surveys were completed. We've had 99 Georgia counties that have been represented, and we also included some guests from Alabama and California. Not sure about that one. So star ratings that were calculated are at 4.8, and 56% of participants are new to the Stop the Bleed program. Many of our organizations already have the follow-up skills training scheduled and in place. And if anyone is interested, please reach out to Crystal for any more information on those. We also have been doing our Georgia Stay Safe, Preventing Pediatric Firearm Injuries Toolkit, and materials that was developed by the Violence and Self-Injury Task Force, along with the Georgia Stay Safe Coalition. Many of our partners have utilized the toolkits. Georgia Stay Safe Week was June 16th through the 22nd, and we had a webinar on the 21st on that included 40 attendees. The webinar was recorded, and there's also going to be a link in the minutes on how to get those toolkits if you need those. Just a side note that the National Night Out is scheduled for August the 6th, where communities get together and promote law enforcement and community partnerships. Both of these programs are very good and well received during that National Night Out. We also have preparation underway for Georgia Falls Free Fridays and Falls Prevention Month in September. We'll be working with iPrice and Department of Public Health Injury Prevention Program, as well as Georgia Area Agencies on Aging. And these webinars will be scheduled for Fridays in September, starting at 10 a.m. Some highlights: we have September 6th, Nicole Gaither with the Middle Georgia Regional Commission and Crystal Smith will be doing bingo-sized demonstration, highlighting our trauma system partnership with the Georgia Area Agencies on Aging. Say that 5 times fast. And then September 13th, Emily Brown with South Georgia Medical Center will be a participant in a panel discussion on EMS and fire-based fall prevention initiatives. Our next meeting is scheduled for August 27th. And that is all.
Thanks, Carrie. Has Cheryl been able to join us yet? I want to give her a few minutes in the sun. The next thing we need to go to is new business, and that's the nomination for GCTE vice chair for the 25-26 rotation. At the end of this year, I'll be rotating off as chair. Lynn Grant will be moving up to the chair position. She's been vice chair for the last 2 years, and I've received one nomination for vice chair, and that's Jamie Van Ness from Kennestone. We'll consider that, and then Liz, don't we vote at it vote on that nomination. Jamie, do you accept this nomination?
Sorry, trying to get off mute. Yes.
Thank you. And I didn't twist your arm or anything, did I?
You just threatened to run me over. It's okay.
Okay.
I'm just kidding.
Liz, can you comment? Don't we vote at the next meeting?
Yeah, you usually vote in November. And that
Okay.
was the least forced vice chair nomination I've ever seen, Jamie. Great job.
That was, sorry, I missed that. What'd you say, Liz?
That was the least forced vice chair nomination. Normally it's always under duress, but this group's always had a great bench depth. So appreciate that and good succession planning. So it'll be great.
So then we'll vote at the next meeting for the vice chair. Thank you, Jamie, for agreeing to be nominated. So the next thing we have is, as we started last year, is going over the new ACS standards. And the two standards that we're going to go over at this meeting are the very first one in the book, administrative commitment. And then the next one we're going to talk about is always one that's near and dear to everybody's heart, and that's registry staffing. So the first one applies to all trauma centers 1, 2, and 3, and the pediatric trauma centers 1 and 2. And it's really the teeth behind a lot of the other standards too, in that trying to enforce and make sure that a facility and its governing body give teeth to all the standards as far as staffing and having the responsibility and enforcement to do what they need to do for the program. So it talks about primarily is that you have to have the letter is a measure of compliance, and that's typically something from the governing body and the Med Exec committee. Usually it's also signed by your COO or CEO. I know that at a survey in the last couple of years, they did not have, I heard from another state that trauma program manager was supposed to be over 2 programs, and it was a level 1 trauma center, and they pulled out this standard and said, you know, number one, that doesn't meet the standard for a level 1, should be a full-time FTE. But the other was the administrative commitment. And if you'll notice at the top that this is a type 1 standard, which means if you don't meet a type 1 standard, you just automatically fail your visit, because this is kind of like full stop. This is what you have to be compliant. Then you can be deficient or non-conforming to 3 type 2s and still be verified. But this is one of those type 1s. If you don't get it and you're out of conformity, they call them non-conformities now, then you're not going to be verified. They'll just stop the survey right there. So, and that's how they finally forced this facility to tell this program manager she didn't have to be over the burn program and the adult trauma program. So it is used, and the surveyors know when they can see it. So they're really kind of looking at it the whole time they're there. So sometimes you can pull this out if you don't feel like you're getting the backup and enforcement. It's not really supposed to be a stick, but it does help in giving teeth to the standards that we have. Does anybody have any comments or questions about that? Okay, the second standard we're going to talk about is trauma registry staffing standard. And again, this applies to the 1, 2, and 3. trauma centers and the pediatric trauma centers level 1 and 2. So you have to have at least a half an FTE dedicated to the trauma registry per 200 to 300 annual patient entries. So of course, I would like to think in more of whole FTEs, a 40-hour per week person. So if you say that's a whole FTE, that means that's 400 to 600 annual patient entries. So that is making a higher staffing standard for the registry than what was applied in the Orange Book. You know, I'm somebody who I've got a data year coming up. 2025 is our data year. So I've been talking to Dr. Walker, my CMO, for the last year saying, you know, we need to kind of push up another FTE. You know, you get to that make or break point and you want to stay up and not to burn out your registrars. There's so much more that they do than just abstract data. And they need to validate, they need to understand what they're doing. And you have a lot of other activities that go on with the registry. So, and that's what it talks about in the additional information. So taking into account things like reporting, data upload takes a lot of time, and most of you can commiserate with this. And then also going back for data validation, IRR, and anything that you might do related to TQIP and your PI programs. So it's just very important that you stay there. I've just found it's just like PI. We were just laughing about this in a meeting earlier today that, you know, individually, you know, it's like you've got to repeat something 7 times until people understand it or kind of commit it to memory. But then we say, you know, with the residents, we always have to repeat things 7 times 70. It's a biblical thing. And, you know, you almost have to do this with your the people you report to. So just like with Dr. Walker, it's not that she doesn't want to give me the staffing, but at the same time, she might have her constraints on the hospital side of things. So it's always best to prepare and just keep the kind of conversation and, you know, really checking your staffing numbers, your number of patients. And this is another reason it's really good that we're aligning with the national trauma data standards. We do have this discussion about, you know, just little things as far as including patients or not. But when you do include the patients, you have to think about how that reflects on your staffing. And I finally, just in the last, just this year, this fiscal year, which for us is a calendar year, my productivity for this department is now based on the trauma data and not just activation, which is the only way they had to monitor our numbers. Activations are only like a quarter to a third of the patients that we see. So it's very important that you look at the whole picture and think about that, but keep up and check those numbers a couple of times a year. It's really important. It takes a long time to train a registrar and to make them part of the team. And, you know, you want to hold on to them. You want to retain them. You don't want to burn them out.
Tracy.
Yes.
This is Ashley. I have a question.
Sure.
What do you do if you don't quite meet the 400, but you're over 300? Does that still mean you need a full-time staff member?
So it's saying a half an FTE for 200 to 300. So a full-time for 400 to 600. I would say, yes, you would need ideally. Now, you know, again, this is something you have to work with your administrative staff or your C-suite, whoever you report to. And it's really hard at first. And I know you're a little bit newer, plus a smaller hospital, Ashley. So it's hard to talk about because you end up at the smaller hospitals having to wear a lot more hats. But you want somebody who you can train and stays dedicated to that registry stuff. I would just say keep on bringing it up. I would. I would shoot for it and just say, one of the things we like to do is say it's always best practice. And Robin, who works with us and runs our registry, does a great job, but she's always saying, well, best practice is, and just use that terminology. That's a good buzzword, but it is best practice to stay, you'd like to stay at or before the curve, not, waiting till you get past what you should be staffed at. But, it's hard. You're fighting against a lot of other people who are asking for positions. And so I think it just goes along, and also get Dr. Register to back you up. And, if you can be saying the same thing, singing that same song, eventually you'll wear them down. But just go for that 70 times 7. Just keep bringing it up. I meet every month with Dr. Walker, and I've been talking about this now probably 10 months, that we need to add somebody this year, and finally got to agree that we could add it the fourth quarter of this year to be ready for next year. But I think it's more just to shut me up.
Well, thank you. I appreciate it.
Hey, Tracy, it's
Yeah.
Liz. One other thing that might really help you guys, especially when you're in that in-between volume, is if you can go back and run like the last 5 years of numbers. This is helpful not just for historical perspective, but you can actually trend what your percent growth is year over year. And you should be doing that, because now that the requirements have been reduced to 0.5 per 200 to 300, most of you are going to have to, if you're at a busier, if you're at a center that's over 3,000, you need to watch that monthly, because you may grow by a registrar plus annually. So a great thing, and it would be a data-driven response if you ever got it asked from a reviewer, if they said, well, you're right on the cusp for your registry FTE, what is your plan for this? You can say, well, that my historic trends show that my growth rate over the last 5 years has been X%. And we anticipate that by whatever. And the other thing, that allows your facility to plan further out ahead for that FTE need.
And that's a great suggestion, Liz. And that could be just a simple line graph over time, but just to kind of back up that you're not just pulling this stuff out of the air. This is our performance. And I can tell you, doing this for 11 years now, I think we've only had 1 year where we stayed flat, and that was 1 year during COVID. Otherwise, we have grown between 5 and almost 12% 1 year, in our numbers. And to continue that growth, especially in the last 3 to 4 years, and being so stringent on trying to follow inclusion criteria and not put in extraneous patients, that's saying a lot. And so you've got to talk the talk, but that's a great suggestion, Liz, because, I've had to do that several times. They want the data, and that's what's helped me in, convincing them, to show my productivity reports that we aren't underproductive. We are at or above 95% productivity, because the numbers and the number of patients support that. Does any of the registry people have any comments about this, or
Tracy, this is Marie. I do want to highlight in that on that page in that first paragraph, it does say that the count of entries is defined as all patients who meet NTDS inclusion criteria, and those patients who meet inclusion criteria for hospital, local, regional, and state purposes. So once we align with NTDS, this requirement narrows down the criteria to just NTDS patients. So if you're entering records that are outside of the criteria for your own internal tracking purposes, use those counts for those records outside of the criteria as extra justification, or like Tracy said, try to swing it your way.
That's a great point, Marie, and something to think about in sticking to the NTDB criteria is that, when we turn in state reports, or you have to turn in a report for a survey, they're always the state, quarterly reports wants, your query always is state equals yes. So you do meet the state criteria. So you're not stacking the numbers, and you're not having to exclude a lot of patients. So you're not closing records that don't really meet criteria. And then in the same way, you're also, for the verification, they want to know, does it meet NTDB criteria? So we've really been taking a hard look at this in the last, say, 6 to 8 months, and have actually tried to decrease the number of extraneous things we were collecting data on. And even though we might have collected in the past for research, it's like, you can get that out of the EMR. We don't need to do that, or, anywhere we can, trying to cut and be judicious about what we're required to close. So it just takes constant work. And like Liz said, look at this stuff. I think at very least you should look at it quarterly, but if you've got higher volumes, you really should be tracking this monthly. Well, if there are not any other comments, does anybody want to share any experiences or celebrations?
Hey, this is Ashley again. Hey, I do want to share that on Monday, we had a very large Stop the Bleed class that was put on by our trauma program through our hospital at our local primary school. And we had 125 staff members there at the school that took this Stop the Bleed class. So we did the class, and then we did hands-on, and we distributed kits to the school so they can have the kits, because it's a new school, and they had never had any of that training before.
Congratulations. I know that must have been a good feeling.
It was really, really nice. The staff at the school really enjoyed it, and it was something that we did that was very good for our community. And now my daughter goes there, so now I know that she will have competent people to care for her if something were to happen. So that always makes me feel better too.
Anybody else have anything to share? I do want to point out that in the chat, there was some discussion about SIPA, which is, Susanna, help me, is it something pediatric adjusted, shock index pediatric adjusted, I believe, but it's like the shock index for pediatrics. There was some education on that. We're hoping eventually maybe to get it included in the registry, but there is a link to that. If you want some education on that, that link, or that, the link is in the chat. And there was a little bit of discussion that, this, and, it's harder on the smaller centers because they are wearing a lot of hats and doing a lot of stuff. So I want to praise this group, because we're always so willing to help others. When you reach out and say, this is how we do it, it's not the only way to do it, but it's always helps if you can talk somebody through something the first time they do that. I think that trauma program manager toolkit will be helpful once it comes out. And so I just really think that we've got a great collaborative group that is willing to share, and we've done a lot of great work we need to be proud of.
Tracy, I wanted to mention just a thank you to all the folks that have been faculty for this latest blitz that we're doing. Thanks Danielle from Kennestone and Kathy and AC from Doctors, and I certainly don't want to miss anybody. I know Rick works up there with Atrium Help Floyd, Emily and with Memorial, and Julie with Wellstar Kennestone will be joining us for tomorrow's makeup session. I actually won't be there because we'll be doing our regional meeting, but if y'all are interested in just seeing how it goes, jump in at any point in time. We'd love to have you. I can send out the link. There's going to be plenty of space because tomorrow's was not advertised. It's a makeup session for those folks that could get into their registered dates. So you're welcome just to join tomorrow at 10 a.m. to see how Laura and Julie and Emily handle this blitz, and y'all see that it's a lot of fun. We are doing door prizes, so if anybody wants to help with maybe sponsoring a Trauma Llama t-shirt or two, you can do one llama or a whole herd. We gladly welcome some help with that. And there are 9 more sessions left next week, actually 10 if you can count the makeup session. So there's still plenty of room for you in that as well. So if you'd like to serve as faculty for that, our whole goal is to make you look good and bring awareness to the trauma system in addition to teaching Stop the Bleed. So we promise we'll make you look good and you'll have a good time.
Thanks, Crystal. I think it speaks loudly and echoes what we've talked about working collaboratively, because some of those people you mentioned, they're from all over the state. It's not you do have some places that send or go more often. They might have somebody with that one hat, but that really helps out those smaller places that are wearing many hats. So our injury prevention group is very good and a great representation of collaborative work. They help everybody do a great job and get a lot done. All right, well, I get to say the thing that I probably don't like to hear, but maybe you will. We'll give you 45 minutes back in your day. Like that really happens, but so we're through. So for once we didn't blow a lot of air and go long, but thank you for coming together. I've enjoyed this. Make sure that you click the link in the chat or scan the QR code to get your meeting attendance recorded. And thank you for attending.